So in fact, I've reverted to my other suggestion to John, which was a talk about funny turns and TIAs, really. What's a TIA and what isn't, and have we had too narrow a view of what warning strokes are? So that was so that's the subject. I'm always slightly, I don't know, anxious about talking about this kind of thing, because it almost seems like we should have known this for decades. You know, what's a TIA? It's not rocket science. It doesn't need some enormous lab and some special sort of scientific technique. But it's amazing how sometimes we don't know the relatively simple things. Our excuse in stroke has always been that get this to go, is that we're kind of behind the cardiologists, and that this was always my impression when I went into stroke, that the cardiologists were doing amazing things and we were somewhere here. And the excuse used to be that, oh well, we don't really have much funding in stroke research. I got into trouble many years ago for writing various rants pointing out that neither the charities nor the MRC funded much stroke research, and they were paying my salary at the time. It's the same all over Europe. We looked in various countries, and lots of cancer research money, lots of CHD, heart disease research, but very little stroke. And in fact, nothing ever changes. This was NIH funding back in the 1980s, and again, cancer, heart disease, stroke. So that's sort of our excuse, or it was our excuse for being behind. Things have got better. This is, you can't read it, but it's a review I wrote a year or two back for the 20th anniversary of Lancet Neurology, just pointing out how stroke has changed in the last 20 years through just spending a little bit more money, finally funding more research. So we now have thrombolysis and thrombectomy, and acute stroke treatment has changed beyond all recognition, and the outcomes are now so much better. And most of this actually has come from academic research rather than industry research. In many ways, the sort of pharmaceutical bench to bedside approach to stroke hasn't worked. We spent, or companies spent billions in the early 2000s trying to develop neuroprotective drugs, so drugs to give to people who had a stroke that would reduce cell death via the various molecular mechanisms of cell death. And all the trials were negative, despite decades of effort. And it turns out, at the end of the day, that just putting a stick up into the brain and pulling the clot out is what works. And I think there is a lesson there that sometimes the simple stuff works, and the bench to bedside approach doesn't always work. We're lucky locally in the sense we've now got a new research building for stroke, the Wolfson Centre for Prevention of Stroke and Dementia, just at the back of the JR site. If you drive round the back of the JR, then you can see the building as you come up the hill, just opposite the trauma car park. So we have no excuse now for not doing better. One of the studies we've done is a simple epidemiological study, which a lot of local GPs in Oxfordshire have helped with. It was a sort of successor in a way to a study that Charles Warlow started. Many of you might remember Charles in the 1980s, called the Oxford Community Stroke Project. And it's a somewhat larger epidemiological study where we see all acute vascular events, funny turns, TIAs, strokes, coronary events, peripheral vascular events, from a subpopulation of Oxfordshire, nested in these 9 general practices around Oxfordshire. And we try to do lots of interesting physiological investigations and imaging investigations, but essentially it's just an epidemiological study. And one nice thing about it is that we're able to try and see patients of all ages. So 30% of our referrals and our ascertainments are over the age of 80. So we have a lot of strokes and funny turns in the elderly population. So that's partly what I want to talk about today. But it did occur to me in relation to sort of intergenerational fairness. One of the things that we're also looking at the moment, which is interesting, is the increasing incidence of young stroke, which you might not be aware of. But if you can see on the slide here, we've been monitoring the incidence of young stroke, which is arbitrarily defined as under 55. And these are the National HES data, hospital episode statistics, showing that stroke in the young seems to have doubled over the last couple of decades, which seems hard to believe. You'd think, well, this is just routinely collected data. This must be some coding issue or some imaging issue. The incidence of stroke in young people can't possibly have doubled. But in fact, when we look on the ground in our study, we find exactly the same thing, that there's been a fairly dramatic increase in the number of strokes occurring in young people, strokes and TIAs and strokes. And so you think, well, that must just be better pickup of minor events with MRI scanning. It can't be true. But in fact, it's not the case. It's the same for disabling stroke and for minor events. So something strange is going on. And in fact, if you look around the world at all the other studies, as we did in this paper on the right of the slide, then you find it's the same everywhere. Pointed to work, but if you put all the studies together, then young stroke is becoming more common in men and women. Ischemic and hemorrhagic stroke, perhaps more ischemic. The design of the study doesn't matter. And it seems to be Europe, North America, that's where most of the data come from. So there's something very consistent happening around the developed world, which seems to be leading to an increase in risk of stroke in young people. And we don't know what it is, so any suggestions would be very, very welcome. It's the same, as I say, in men and women. Independent of deprivation, that bottom slide there is more deprived and less deprived. The biggest increase, in fact, is in professional classes. One of the possible drivers, or one of the reasons we're not preventing it, is, of course, that prescribing now, particularly in primary care for primary prevention, is based very much on the sort of 10-year predicted risk of vascular events. So you have your blood pressure measured or your cholesterol, and your risk is calculated automatically using the Q risk or similar scores. And if your 10-year risk of a vascular event is not greater than 10%, then often you're not treated because you're thought to be too low risk. And in fact, all of these young strokes, when we look at them, pretty much all of them have Q risk scores of less than 10%. So even though they might have been hypertensive, their risk wasn't high enough to treat. And that's the case in virtually all the women, because the scores are very much weighted against women. So I think part of it is that our prevention has been undermined by relying too much on risk scores that are derived and calibrated and meant for use at older ages, but applying them to younger people where they just don't apply. The risk factors are different. They don't include important things like family history of stroke or pregnancy complications like hypertension. So that's one aspect of it, but there's something else going on, which is driving an increase in young stroke, which may be related to infection or other factors. So that's the other end of the age spectrum, which wasn't really what I wanted to talk about, but I thought I'd mention it because it's interesting and you might have some ideas. In terms of funny turns, this is our annual incidence data on the rate of sort of classical TIAs, as you might call them, and then two other groups of funny turns, what people call non-consensus TIAs, where there's disagreement about whether or not these events are TIAs, or there was disagreement, and I'll talk about those. And then the very sort of possible TIAs, but very atypical, with progressive neurological symptoms, non-focal symptoms, the sort of more senior moments, as you might call them. And I'll say something about those. But clearly, incidence increases with age, as it does for stroke. But if you added together the other funny turns that could be TIAs, they come to about the same number as the definite classical TIAs. So they're quite common. It's a largest number of people affected. So TIA, as you know, as a concept, goes back a long way. It was Hippocrates who first noted the link between these transient neurological symptoms and a subsequent stroke. And then there've been many sort of steps forward along the way. It was Lawrence Craven, was a GP in California, who very observant physician, who first noticed, in fact, that aspirin might have a role in preventing TIAs and strokes in the 1950s, publishing his work in the Massachusetts Valley Medical Journal, which no longer exists, sadly. But up until that point, as you may know, people have used aspirin since it was synthesized in the late 19th century, but purely as a painkiller. And at that point, it wasn't realized that it had any antithrombotic effect at all. But Lawrence Craven noticed that his patients who were on aspirin, who went to the dentist, bled a lot more, and then noticed that, in fact, it seemed to prevent MI, looking at his patient population, and might also prevent little strokes, as he said there. So that was a step forward in terms of the idea of little strokes and antithrombotics possibly helping. And then Miller Fisher, the great Miller Fisher, famous for his neurological syndrome, also made his sort of day job was cerebrovascular disease, and he first coined the term TIA in the 1960s, and also developed the idea of lacuna stroke, cardioembolic stroke, and thromboembolic stroke from carotid disease. So an enormous contribution. And Henry Barnett, the late great Henry Barnett, was the first person to do a trial in stroke, and he showed that antiplatelet drugs reduce the risk of stroke in secondary prevention. And I love the term that he used for TIAs. It was threatened stroke, which I think is probably the best term that we've come across so far. And that was nice in the sense that Barney's trial led the FDA to approve aspirin or antiplatelet drugs in secondary prevention of stroke 10 years before they were approved for MI. So that was a rare first for stroke. So there's a lot of history. One of the things that was very important, and I'll say a little bit more about in a minute, was this consensus statement in the 1970s at NIH, where they got various experts together, not that many years after the concept of TIA had been elucidated, and tried to define what a TIA was. And in fact, this guideline still applies today, and it's one of the things that we've been trying to research and understand more, that is the definition too narrow. And of course, there's been other work. Charles Warlow, my old boss and mentor, did a lot of work in Oxford about different TIA-like syndromes. He also wrote some very important papers on transient global amnesia, showing that was a benign syndrome, not commonly associated with stroke. So it's not new territory, but it's not an area that's been that well researched. One of the problems was that for many years, TIA was thought to be a fairly benign syndrome, and patients were referred sometimes to hospital, to a neurology clinic or whatever, and often seen weeks or months after the event. So the early epidemiology of TIA was based on these sorts of cohorts where patients didn't get into the study until often several weeks after the event. And so at that point, the risk of stroke seemed pretty low, around 1% at 1 month, about 0.5% at 7 days. So, that seemed not really an emergency in the same way that unstable angina is an emergency, for example. And it's only by beginning to see people more quickly that you begin to be able to see the early risk of stroke. When we audited our weekly TIA clinic back about 20, 30 years ago, we found that about 15% of patients didn't turn up. So there's always DNAs in the clinic. And it turned out the most common reason for DNA was they were on the stroke unit because they had a major stroke whilst waiting for the clinic. And so it's one of the rare examples of audit being useful in making us realize what we were doing wrong. So we started a daily clinic, still with a delay, and then eventually a same-day service, which we tried to continue where we can. So when you do that, you get a very different epidemiology. So rather than the sort of 1% risk of stroke at 1 month, if you see people immediately, you find the risk of stroke is much higher, as all the DNAs are now in your cohort rather than recruiting out here. And so we bored people senseless with all sorts of papers on the high early risk of stroke after a TIA. And in fact, even within the first 24 hours, it's a sort of time is brain thing rather like major acute stroke, but the risk of stroke is quite high over the next 24 hours. So the epidemiology we'd got wrong, and it was higher risk than we'd thought. It also became apparent that you could do something about it. For example, on the right here, we did something called the Express study, where we compared our initial service, which was a daily clinic where we saw patients as soon as we could, but didn't initiate medication. We would fax a letter to the primary care physician in the study, this is the Oxford Vascular study, and say, yeah, we agree, we think it's a TIA, please could you consider starting aspirin, statin, blood pressure lowering drugs. And of course, people did, but the patients often took quite a while to get back to the GP. The prescription didn't happen often for a week or 2 weeks or 4 weeks. And so we hadn't really impacted much on the natural history of TIA. So we changed on one day after 2.5 years and just started giving all the medication ourselves in clinic. And we then looked at this 2.5 years later and found there'd been a dramatic reduction in the early risk of recurrent stroke, just by giving the patient a glass of water with some aspirin and starting the other drugs ourselves. And so it looked as though this was non-randomized before and after study, but it was population-based, so we had everybody before and everybody after. So there weren't really any selection biases, and we had Charles Warlow assess all the endpoints. And there was a similar study published a little bit later from Paris that came up with a similar estimate of about an 80% reduction in the early risk of recurrent stroke, just by giving people existing medications straight away. And I'll come back to that at the end. The other thing that we found out about the same time was when we put all the data together for the old carotid endarterectomy trials, which I've been involved in as a boy working for Charles Warlow. Not surprisingly, if you look at the benefit from surgery, so this is the absolute benefit. If you operate within 2 weeks, 2 to 4 weeks, 4 to 12 weeks, greater than 12 weeks, of course, the benefit is much greater if you catch people early and manage to remove the carotid stenosis after a recent TIA or stroke. At that point in the UK, we were operating at about 4 months on average. So we were just wasting our money. We were achieving nothing in terms of preventing strokes, but that was because patients were seen very late. And so we had a problem that we suddenly realized we ought to be seeing these patients straight away rather than waiting for several weeks. But across the UK, there wasn't a clinic service set up that could do that. And the numbers were fairly substantial if you work them out. And so we tried to come up with risk scores. This was one of them, the ABCD2 score, to try and identify which patients were very high risk of an early recurrent stroke and which patients were lower risk. And that was of some use. And it was only ever meant as a sort of temporary way of triaging people so that while services were building up to be able to see patients more quickly, we had some way in that intervening period of seeing the high-risk patients more quickly. And eventually, with input of many people, we managed to get the guidelines changed for stroke. So in 2007, the NHS National Stroke Strategy declared that all hospitals in the UK should have a daily service for TIAs and minor strokes. So now all hospitals, in theory, provide a same-day urgent service for TIAs and strokes. So that's been a real change. But of course, it's all predicated on the assumption that we can actually diagnose TIA and we actually know who to refer and what sort of symptoms are high risk. It's all very well providing a service, but you have to be seeing the right patients. And of course, if you look at the definitions of TIA, they don't really help. So the WHO definition is a sudden onset focal neurological deficit, presumed vascular in origin, lasting less than 24 hours. So, you have to really know what presumed vascular in origin means. It doesn't actually, it's a bit circular. It doesn't help other than saying the symptoms have to be sudden onset and ideally focal rather than just a blackout or some other generalized neurological symptom. So that doesn't help. And yet, as I say, most patients or many patients don't fall into that category. The sort of classical sudden onset focal TIA is the most common, but there are a great many other funny turns that don't fulfill that criterion. And so people still go back to the original NIH 1975 guideline on what is a TIA. And that was an expert consensus, and it was very good. I think it was the best that could have been done at the time. But it was very didactic, and I think that was the time really. And so they said things like, obviously it has to be focal, sudden onset, non-progressive, and that certain isolated symptoms on their own were not a TIA. So they were quite categorical that a TIA cannot be vertigo alone, slurred speech alone, difficulty swallowing alone, double vision alone. And then they repeat that for the sake of clarity. These things are definitely not TIAs. So it was very clear cut, and that got into the guidelines and into the textbooks, and it continues to be said. But it wasn't based really on much evidence. It was just expert opinion. And I remember some years ago we looked at in our population the symptoms that people have prior to a definite stroke over the weeks and days and weeks prior to a definite stroke, wondering whether a lot of those episodes, transient double vision, transient vertigo, transient slurred speech, surely they could be posterior circulation TIAs. And if that were the case, they should precede perhaps posterior circulation strokes more commonly than carotid strokes. And in fact, when you look at that, that's exactly what we found. So the TNAs in blue here are these sort of non-stroke, non-TIA funny terms like these transient monosymptomatic events like vertigo, slurred speech. And they're very rare prior to, this is time since the stroke, this is day before the stroke, going back a few weeks. And nearly all the events prior to a carotid stroke are carotid territory TIAs, the sort of classical TIA type definition, and there are very few of the other funny turns. But if you look at posterior circulation strokes, so vertebral or basilar strokes, then in fact, nearly all the events prior to those just coming up are these isolated brainstem type symptoms. So it looked as though there probably was evidence that these were TIAs. And so we then looked prospectively to see what the risk was by prospectively categorizing all the patients we saw into classical TIAs, so motor weakness, dysphasia, hemianopia, or a combination of these symptoms with brainstem type symptoms, or the non-consensus TIAs, as it were, the ones that the guidelines said weren't TIAs, so isolated vertigo, isolated unsteadiness, isolated diplopia, isolated slurred speech, and followed them up to see what happened. And we had the advantage that people didn't have in 1975, that we've got much better brain imaging now. And so particularly we've got something called diffusion weighted MRI imaging, which, as I'm sure you're aware of, shows ischemia as these very bright dots here. So it's identifying small infarcts. And in fact, just through routine clinical practice, one comes across patients who just had transient double vision or transient slurred speech or transient vertigo, transient unsteadiness, etc., bilateral visual disturbance, these things that aren't supposed to be TIAs, and they have acute ischemia on the DWI. So that makes it much easier. The problem is, of course, only about 10% of TIAs have a positive DWI, so it's fine when it's there, but in 90% of patients, you don't have that clue. So you're relying on the epidemiology mainly. So we followed these patients up for 10 years to see what the risk of stroke was. And in fact, if you look at at minor strokes, so definite strokes, this is their risk of recurrence over the next 10 years, a high early risk, and then flattens out a bit. If you look at the classic TIA, the sort of NIH definition TIA, then again, that's high risk as well. But in fact, if you look at all these non-consensus events, then they were also high risk, almost identical. And so the prognosis was very similar. The risk of stroke was the same. So in fact, the guidance that people have been given was too narrow. These other events were TIAs after all. And I won't go into the details. We didn't really have the numbers to break them down into the different symptoms: isolated double vision, bilateral blurred vision, isolated vertigo, isolated slurred speech, but they all seem to have an early risk of stroke, which is sort of pathognomonic of a TIA. And so that was helpful. So those are the non-consensus events. And what was interesting, as you might expect, when we looked at any arterial stenosis that they might have on vascular imaging, the standard classic TIAs, which are mainly carotid territory, had quite a lot of carotid stenosis, whereas the non-consensus TIAs, these isolated events, had much more posterior circulation, vertebral or basilar stenosis. And so it fitted perfectly, both the prognosis and the investigations. These events were, in fact, TIAs. So that's been helpful in terms of broadening the definition of TIA a little bit. We can now add the non-consensus isolated brainstem type symptoms to the TIAs, but we're still left with the atypical possible TIAs. So these are events that are either gradual in onset, they're progressive, they're not sudden in onset. They might have some positive symptomatology rather than purely being negative. So we're taught that TIAs are always a loss of function. So if you have tingling rather than numbness, that can't be a TIA, that's possibly a seizure. If you have bright lights, so flashing lights in your field of vision rather than a migrainous type visual disturbance, that's positive, and so that can't be a TIA, it's not a loss of vision. And so we have a lot of these symptoms that are gradual onset, positive symptoms, and also non-focal. So we're taught that a TIA always has to be a focal loss of neurological function. So if you just become a bit vague or confused, it's a sort of senior moment, then that's not a TIA because it's not focal. Or if you have a hazy blurring of vision, that's not a TIA because that's not focal. And that seems like a double standard in a way, because we're happy with the concept of vascular dementia. So we're happy that strategically located strokes or multiple strokes can cause dementia, but we're not happy with the idea that transient ischemia can't cause transient confusion, which seems at least inconsistent. So we've been doing the same thing, following up all the funny turns that don't really qualify at all as TIAs, but could possibly be, to see what their investigations and prognosis show. And again, these are the ones that the guidelines definitely forbid us from calling TIAs. So migrainous like visual disturbance, scintillating scotoma, confusion only, amnesia only. These are never TIAs. And of course, you do get a lot of patients referred to a TIA service or a funny turn clinic with other diagnoses, and we wouldn't want to call everything a TIA, obviously. So there's a lot of migraine, transient global amnesia, seizures, peripheral neuropathies, brain tumors, etc., all the things that you might expect: syncope, vasovagal, peripheral causes of vertigo, anxiety, the usual list of things that cause neurological symptoms. So even when you separate out those, but then you're left with that large number of atypical possible TIAs where you can't come up with another obvious diagnosis. Doesn't sound like a typical TIA, but there's nothing else you can use to explain this suddenly untoward neurological symptom that the patient's obviously concerned about. And so that was really the question: what are these other events? And we try to screen for cardiac causes, for example. So everybody gets a 5-day cardiac rhythm monitor. If you're in the US, you get an insertable permanent cardiac monitor that runs for at least a year, mainly looking for paroxysmal atrial fibrillation. And the longer you monitor, the more of that you find. But we also look for pauses and other things that might have caused some transient neurology, but we find very little of that. So these events don't seem to be cardiac in origin for the most part. And again, we've got the advantage that people didn't have years ago of having these scans, the DWI scans, where you get transient cognitive processing, transient neurological attacks, as it were, sort of stopped talking for 5 minutes, didn't respond much, seems not to be all there, but the patient thought they were fine. They remembered the event, or sudden confusion for 10 minutes, which wasn't speech related, but brain just wasn't processing. And that's a very common story. And when you do the DWI, sometimes you do find multiple little ischemic lesions. And then the migraine-like TNAs, positive visual disturbance, usually with headache, and sounds very like a migraine. But this is a 71-year-old lady that's never had a migraine before. So it'd be odd for it to come on at 71. But these always get diagnosed as migraine because there's headache and positive visual disturbance. But again, quite often you do find an ischemic lesion on imaging that probably explains it. And of course, the difficulty with the confusion type presentations is people often go to A&E, and then someone, of course, dipsticks their urine and finds a tiny trace of protein, in which case, of course, it's a UTI. It's a sort of dustbin diagnosis for any sort of confusion in anybody over 70. If you find something in the urine, then it's a UTI. And so all of these patients are dismissed, and very few of them ever get a TIA diagnosis, or at least the investigations that might be appropriate. And so that's the group that we're looking at. And it's right, of course, that you don't just cast a net too wide and treat everybody, because the medications that you might use, such as antiplatelet drugs, are not safe, and the bleeding risk increases fairly dramatically with age. This was a study we did in our patients, just looking at the risk of major bleeds on long-term follow-up on antiplatelet therapy with age, and it goes up fairly dramatically. All the randomized trials were done in people in their 60s, where the bleeding risk is relatively low, but once you get into your 80s, the risk of major bleeds, disabling or fatal, is a lot higher. And this was one of the things I hadn't fully appreciated. Nearly all of these are GI bleeds, and you think, well, GI bleeds shouldn't be disabling or fatal, but so often they are. Someone frail, 85-year-old, comes in with a big GI bleed, and they don't do well. They perhaps don't regain mobility, they've fallen out of bed, fractured their hip, their cognition doesn't fully recover. So this idea that GI bleeds and antiplatelet drugs are just an inconvenience, but what's the worst thing can happen? A transfusion really isn't the case, as I'm sure experienced clinicians would say anyway. But we did find a high proportion of bleeds over 75 did lead to an increase in disability, which didn't happen in younger people for the most part. So it wouldn't be right to cast the net too wide and diagnose everything as a TIA. There is a downside. And there are also a group of patients with this condition called cerebral amyloid angiopathy, which is a disease of the very small vessels in the brain, which causes bleeding. And that does cause as well transient neurological symptoms, a little bit like the ones I've been talking about. And you often see on the scan, this is some subarachnoid bleeding, some old hemosiderin on the MRI scan from what's been subarachnoid bleeding, or often these patients have multiple microbleeds within the brain. So this is a hemorrhagic pathology rather than where it's a mixed hemorrhagic ischemic pathology. So again, you wouldn't want to miss this and put all these patients on combination antiplatelet therapy. So it's important to be careful in making a diagnosis of TIA. And indeed, these patients, interestingly, with the atypical possible TIAs, if you look at the risk of intracerebral hemorrhage or subarachnoid hemorrhage on follow-up, they are higher risk of that somewhat than the more definite TIAs. And if you look at those where we're able to do an MRI scan and you find these microbleeds, then the risk of a bigger bleed on follow-up is a lot higher than in those without microbleeds. So this is an issue, the downside of giving antithrombotic treatment. But overall, that risk is relatively low compared to the risk of a major ischemic stroke. And so if we look at that, then, and now we're looking at not the non-consensus TIAs, we're looking at these really very funny turns, the atypical possible TIAs, and this is the 10-year risk of stroke. This is the minor strokes, again, the definite strokes. This is the classical TIAs, and this is the funny turns, the atypical possible TIAs. And they have a slightly lower early risk, but it's still increased of stroke, but they do catch up over time. Most of the events are ischemic. So these probably are in many cases TIAs. If you look at the actual symptom type, then it's the transient confusions or the transient unresponsiveness that has the highest risk of stroke over the long term. And so these events are probably not UTIs, they probably are ischemic in nature. So that's helpful in terms of knowing what we're dealing with. And because this study is nested within a population-based study of all TIA and stroke, we can calculate exactly for each individual what their expected risk of stroke would have been over 90 days and over 10 years. And you can compare the observed versus expected risk of stroke in these different syndromes. And so the typical TIAs have about a 30-fold increase in stroke risk over the first 90 days compared to the expected rate. But the funny turns, the very atypical TIAs also have about a 20-fold increased risk of stroke in those first 90 days, and in fact higher long term. So they definitely are different to the mimics and the expected stroke risk. So they do seem to be, in the majority of cases, TIAs. And in fact, when you just stratify by there's something called the Essen score, which is a little score to predict the risk of stroke longer term, just based on age and the number of vascular risk factors, very simple score, then the atypical TIAs, the funny turns, have just the same pattern of stroke risk. So if you're older and you have risk factors, the stroke risk is just the same as the classical TIAs and the minor strokes. Equally, if you're younger and you don't have risk factors, a low Essen score, then the risk of stroke is very low, which is helpful because so often the lower age limit here is 65. So this is someone under 65 without vascular risk factors, and then someone under 65 with vascular risk factors, and then older ages and more risk factors. But it does help in the sense that the low score patients have a low risk of stroke. And of course, so many of these people are taxi drivers, bus drivers, they need to drive for a living. And the other downside of overdiagnosing TIA is that you can ruin people's lives, careers, and financial situation, because you can't hold a PSV license or a HGV license for a long time if you have a TIA or a minor stroke. So it's important not to get that wrong. But when you stratify by age and risk factors, the clinical symptoms really don't matter. So what we thought was important, getting the diagnosis right using the narrow criteria, actually doesn't really help. The funny turns are exactly the same risk when you compare like with like. You can look at those with and without those little dots on the diffusion weighted MRI, the little strokes that you can see, and that's the risk of stroke in that group. The thick line is the DWI positive patients, and these are the DWI negative patients stratified by the Essence score. And again, there are groups of people with a normal scan who have these funny turns, who have a risk of stroke just the same as the classical TIAs. So the scan doesn't help. And of course, as I say, about 90% of the TIAs have a normal scan. Once you have a minor stroke, these are all minor strokes with increasing severity, the scan's more likely to be positive, but the TIAs, it usually isn't. So you have to make a clinical assessment. So it turns out, I think, that in fact, both of these groups are TIAs for the most part. The atypical brainstem isolated symptoms, the slurred speech, the vertigo, and then the vaguer sort of not quite focal, gradually progressive positive symptom groups are also in many cases TIAs. And I think the message really is if someone has some transient neurological symptoms that they've never had before, they seem untoward, they're worried about them, unless we can come up with an alternative diagnosis, then we shouldn't dismiss them and send them home and say, don't worry, dear, it's nothing to worry about, which is what happens at the moment. There's lots of false reassurance, not based on any decent evidence. The problem, of course, is how do we get that message across to the public? Because we can set up a clinical service, but we need the patients to seek medical attention. And one of the problems we've always had, it's from a long time ago now, is that people don't seek attention, particularly at weekends, as you might imagine. This is a delay in seeking medical attention after a TIA by day of the week of occurrence. And if it's on a Monday or a Tuesday, many patients, same day, next day. But of course, once it gets to the weekend, people don't want to bother primary care or sometimes even go to ED, so that they wait till the next week. So there's always a delay of a few days after the more minor events. And you'll be aware of the FAST television campaign to try and increase recognition of stroke, the facial weakness and the hair on fire, etc., which may or may not be confusing, but it has helped reduce the delay in seeking attention after major stroke. So this is each of the FAST campaigns here. These vertical lines are the FAST television campaigns. And you can see for major stroke, having really not changed much in terms of non-emergency presentation, about 40% of patients with a major stroke didn't seek attention immediately. Following the FAST campaigns, that has come down quite dramatically. But it hasn't changed much for the minor strokes and the TIAs. Patients still aren't sure what it is. They don't want to bother the doctor or the system. And so they wait a few days or wait till their daughter sees them next week, and then they're encouraged to seek attention. And that hasn't been helped by the FAST campaigns. So what can we do to try and get around that? One possibility is aspirin again. And if you look at the guidelines for MI for the public for chest pain, they all say if you get sudden onset chest pain, call 999 or 111 in the US and take an aspirin. That's what the guidelines have been saying for 20 years for MI. But for TIA, they don't say that. They say seek medical attention, but no one mentions taking aspirin. And in fact, I think, I'll show you, there's some good evidence that perhaps we should be doing that. The guideline would be if you have transient untoward neurological symptoms that get better, i.e. it's not going to be a hemorrhagic stroke because it's got better, then seek medical attention, but in the meantime, take an aspirin. And I'll show you the evidence for that. I do like this slide. Many of you are probably aware of Felix Hoffmann, who was the pharmacist working for Bayer, who first synthesized aspirin from salicylate. Salicylate's been around for centuries, but it's very unpleasant to take. It causes a lot of burning in the mouth and throat. And so for a long time, people have been trying to modify it to create something that was more palatable. And he did this in 1897. It came from Spirea, meadowsweet, and he acetylated it, so he called it aspirin. In those days, all drug names had to end in in, so it became aspirin. In fact, in that same week, he chemically modified an opiate and gave it to various family members and friends, which what people did with drugs in those days. You just tested it out on people you knew. And several of them said it made them feel heroic. So he called it heroin. So in the same week, this chap came up with aspirin and heroin, which is quite an impact. Anyway, that's by the by. But it's interesting because when we started treating the TIAs more aggressively, giving them their medication on the same day, it was really hard to work out what on earth had caused that reduction in recurrent stroke risk. You know, you gave them a statin, but that's not going to work immediately. We gave them blood pressure lowering drugs, but they take a while to work, and often patients need 3 or 4 drugs sometimes to control their blood pressure. So the only thing it could have been is that we gave them the aspirin with a glass of water and said, please take this, and watch them take it. But then that doesn't make sense, because you look at the meta-analyses like the Antithrombotic Trialist Collaboration, and they've looked at aspirin in TIA and stroke. And yes, there is a bit of benefit, but it's a small reduction, really, about 15%. It wouldn't, you'd have thought, result in that sort of benefit. But in fact, these were randomized trials that treated patients for a long time, for 2, 3 years or more. And people hadn't looked at the time course of the benefit. Perhaps that long-term benefit was all up front, for example, and it wasn't inconsistent with what we found. And in fact, when we eventually got around to doing that some years later, that's exactly what we found. These were individual patient data from the old aspirin trials after a recent TIA or stroke. And this is the benefit by time. So the reduction in stroke risk in the first 6 weeks, 6 to 12 weeks. And in fact, all the numbers are here, because this is where the follow-up was beyond 12 weeks. So the overall result was based on not much effect after 12 weeks. But in fact, there was hidden within that this big acute benefit within the first few weeks. And in fact, if you look at disabling events and acute MI, then aspirin reduced that risk by about 80%, which is what we subsequently found. But these data were all hidden away in basements from these old trials. And in fact, aspirin also reduced the severity of recurrent stroke as well as the risks. The impact was particularly big for disabling stroke. So just giving an aspirin does make a big difference. And these are now randomized data rather than our observational data. So I think things have improved with TIA, both in terms of the recognition of what a TIA is. It's a broader clinical phenomenology than we thought. I think probably we should be advising the patient public to take an aspirin if they have any sudden onset, untoward neurological symptoms that they've not had before and seem a bit odd. Then why not just take an aspirin for a few days? People take aspirin for headache all the time. It's not as though we're suggesting they do something which is unusual. The worst that can happen is that they take an aspirin for 2 or 3 days until they're seen and investigated, and then they stop. And the risk of that is actually not very great. But I can't tell you how hard it is to get the guidelines to change and to suggest that to the public, because I think the benefits would dramatically outweigh the risks. So there are a few guidelines now, Australia, New Zealand, and 1 or 2 other countries that have changed, and they now recommend aspirin immediately after after transient neurological symptoms, but other guidelines are not yet changing because of anxiety about the risk. And there really isn't a risk. Even in acute major stroke, there have been trials, big trials of acute aspirin and acute stroke, one in the UK and one in China. And interestingly, these were sort of 20 years ago. And so you were allowed to randomize patients in the trial before they had a CT scan. It was clearly a stroke, but it could be the hemorrhage, could be an infarct. If you thought it was an infarct, just randomize them, give them the treatment, and then get the scan when you can. And so there were about 1,000 patients in the international stroke trial in the UK and other countries in the West that were randomized with a hemorrhage, unbeknown to the clinicians. And those patients with a hemorrhage were randomized to aspirin did a lot better, somewhat better than those randomized to placebo. So the idea that aspirin is dangerous in that situation doesn't really have much evidence base at all. And so in someone with a TIA, where it's so unlikely to be hemorrhagic, but the risk of ischemic events is so high, you think, why is it such a difficult decision to recommend that people take aspirin? Anyway, sorry, I'm going on, but there we are. We've got a little bit further than we had 30 years ago, but not really that much further. And the major work was all done by Miller Fisher and Lawrence Craven and Henry Barnett and Charles Warlow. So I'll stop there. Thank you.